Good morning, afternoon and evening. This is the conference operator. The European School of Oncology welcomes you to their 325th e-grandround. Today's session is Malignant Fungating Wounds. Session held in collaboration with IONS. Questions will be received by Dr. Georgina Gethin, of the National University of Ireland, Galway, Ireland, who will discuss them with Dr. Sebastian Probst, of the Zurich University of Applied Sciences, Winterthur, Switzerland. I will now hand over to Dr. Probst. Doctor, your line is now open.
Hello and good evening, good afternoon, good morning. I will talk about the clinical recommendations for fungating wounds. And as you probably have heard, we wrote a document about these wounds where I present now. The presentation will be, first I give you an introduction and definition of fungating wounds. Then I will talk about assessment of patients with malignant fungating wounds. Then I will talk about symptom management of malignant fungating wounds, psychological impact, and some take-home messages. Please write your questions to my colleague Dr. Georgina Gethin so we can discuss those together. When we talk about fungating wounds, we see most of these wounds on breast, that means from breast cancer, and patients with these wounds are vulnerable to tissue breakdown that may not always be preventable. When you look in the literature, you find only a few little evidence about palliative management of fungating wounds. That means you find mainly case studies, a couple of RCTs, and some qualitative studies. Most of these studies, as I've already said, that are are case studies, and these are based on problem solving. But what is a fungating wound? A fungating wound is an infiltration of the tumor, be it from breast cancer or other cancer types, or the metastasis into the skin, and it can involve the afferent blood and lymph vessels, and it can develop anywhere in the body of the patient. Let's talk about the prevalence and the location of these wounds. When we talk about the prevalence, there are always estimates. We find in the literature that there is about over 5% of patients with cancer that develop a fungating wound. I can give you an example of Switzerland, where I'm from. We conducted there a survey, and we found that about 6.6% of patients with the cancer develop their fungating wound. The most frequent sites for presentation of fungating wounds is the breast, with about 50%, followed by neck, chest, the extremities and genitals, head, and other areas like arms. When we talk about fungating wounds and assessments, and we are in the clinical side, we have to do a comprehensive assessment that is taking account of first a physical, a psychological, and a psychological considerations. It will provide a substantive baseline upon which to develop a management plan for fungating wounds. It's important that when you take care of a fungating wound, it has to be systemized, this assessment, and it has to be a comprehensive approach. Again, please, if you have any questions, ask them and write them to Dr. Georgina Gethin. Let's talk about fungating wounds and assessments and the management. Fungating wounds, they have a big impact in terms of psychological, as I already said, aspects. It has a big impact as well on the wound and in the wound management on the caregiver. So that means you have to involve the caregiver in the management of your wounds. Further, you have to know about the underlying etiology, what cancer type do we find there, and if it's known. Then the wound location and appearance, where do we find this wound? How does it appear? Is it fungating? Do we have a cauliflower? Do we have a crater? Or is it an ulciform? And further, what are the past and current treatments of the cancer and of these wounds? What kind of products, for example, were used? Then, what comorbidities does the patient have? Does he have a diabetes? Does he have any peripheral vascular diseases or other diagnoses that are other diagnoses? Then we have to be aware about the major symptoms arising from these wounds and arising from their underlying diseases and comorbidities. We will talk about the symptoms in a few minutes. Then, what are the medications that are prescribed for managing the symptoms arising from the malignant fungating wounds? And what dressings have been tried but not found suitable for the patient or even the informal carer? And does the patient have any allergies, sensitivities due to dressings, to products, and or to adhesive tape that may damage the surrounding skin? When we were thinking about all these questions, we have to look for a tool that suits our patient. When we go to the literature, we can find 5 different assessment tools for fungating wounds. We have the Toronto Symptom Assessment System for wounds. Then we have the Schultz Malignant Fungating Wound Assessment Tool. There you have one for the clinical practice, and there is one available for research. Then the wound symptom self-assessment chart, as well as the Teller system, or the oldest one we can find, the Hopkins wound assessment tools. There you have, for example, they took the pressure ulcer guideline, the pressure ulcer assessment tool, and adapted it to the fungating wounds. Do you have any questions?
Dr. Post, can you hear me? This is Dr. Geppa.
Yes, I can hear you.
Okay, one of the questions I've had is there a particular assessment tool that is used most frequently or that you would recommend from experience?
There are all assessment tools are used pretty frequently. There is one big problem that all assessment tools are only available in English. There is no assessment tool translated into any other languages. The one for if you want to do a profound assessment, I can recommend the Teller system. If you want to have don't have that much time in clinical practice, you can use the Hopkins one.
Thank you.
Do you have any other further questions?
No more questions at this time, but we'll...
Okay.
Thank you.
you. So I will continue, and I will talk about the management of the different kind of symptoms that occur from a malignant fungating wound. We start with malodor. Malodor is one of the most difficult to treat symptoms that we can find. It has a profoundly negative impact on the quality of life of patients and of their informal carers. Most of the patients and the informal carers, they tell us that the smell is like rotting meat, and you can imagine most of the patients, they feel guilt, repulsion, and leading to social isolation, even to depression. Then most of them, they feel embarrassed. And if you try to manage these wounds with the malodor, it involves both containment of odor and the treatment of its cause. What can we do as clinicians? Of course, we can clean the wound with saline, with other products. In some countries, you can even use the shower. There you have to be careful of the pressure, and you can use the regular dressings that control mainly also the exudate to reduce odor. Further, what we recommend, even in our guideline, is that you use metronidazole, mainly 500 milligrams. This can be given topical or IV. There is even a gel or the injectable nitazole that can be applied. You can use that as a wet dressing on top of the wound, or leave it there, or you can use it only for a couple of minutes. Other dressings that we can recommend is silver dressings, or activated charcoal dressings that can help to contain odor. Further, we have to think about the environment, and there we have 3 different kinds of actions where we can take. That means we can do either the odor absorption or the room deodorizers or odor masking. Odor absorption, we can recommend shaving foam. So you take a bowl, you put shaving foam in there and put it on a chair or somewhere in the room and leave it there, and this helps to absorb this odor. You can even use cat litter. For example, you can put cat litter at home in the pots. You can also use charcoal coals. Room deodorizers, there you have different brands available on the market. For odor masking, we have the aromatherapy oils like bergamot, patchouli. I know patchouli has a very particular odor, but with the odor of these wounds, it can help to mask this dreadful odor. Or you can use lavender. Dried sage is another possibility, or aceto balsamico. We know that from Italy, where you find that in different kitchens. Then we talk about pruritus. This is another symptom that is reported by patients. There we can suggest that you can apply cool hydrogel sheets or products with menthols or capsaicin ointment. There you find different products. you find that this capsaicin ointment, for example, is available in 0.25 till 0.75 per ml, and it has to be applied on intact skin conditions. Otherwise, you can ask patient to give some additives to bath, like milk and honey, or it is important that it has to be a specialized non-perfumed oils or oatmeals you can do as well, or and of course patients can take these baths only if the skin is intact. Further, you can even recommend some linen, that patients are wearing linen dresses, so it's more comfortable for them, and that helps to prevent itching or helps to minimize the itching. Are there any questions, Dr. Gettin?
I think there's just one that we'll take at this time, and we'll keep the others for the end. And it follows from assessment. Are there any instruments for assessing odor?
There are different kind of instruments. We just published, or Dr. Gettin published a study. You can, most of the nurses describe odor, but you can even use the VAF scale for odor. There is another scale where you say it's if you feel odor, you can smell odor when you enter the room, by the patient, when you open up the dressing, and you can categorize that like that.
Thank you very much. That's all for now.
Okay. Then we continue and talk about exudate. Exudate is another big problem that we have with fungating wounds, and these wounds can deliver till 1 liter of exudate a day. That means we have to contain this exudate, otherwise we have big problems with the maceration of the surrounding skin. Sometimes we have a lot of exudate, and sometimes we have only a little low exudate. If we have low exudate, we have to try to maintain the most environment and to prevent that dressing adherence occurs or that we provoke some bleeding. We can use regular dressings there, like alginates, or we can use polymers or other absorbent dressings. If we have high exudate, we have to absorb these dressing, the exudate, and to contain especially the exudate. The exudate can be contained with supraabsorbent dressings or polymers, gauzes, or alginates or foams. It is important that we protect the surrounding of the skin, otherwise it is possible that we have maceration. I already talked about a part of the exudate. We have these varieties of dressings I already presented to contain the exudate, but sometimes it is difficult to find a dressing that conforms to the wound shape, wound size, and the body contours. That means that we have to use different dressings, we have to put them together and to see what is the best solution for the patient. It is, of course, the aim to achieve a close-fitting dressing with a good seal to prevent leakage. Prevention of maceration and irritation of the wound. I was already talking a little bit about that. As I already said, we have large amounts of exudate, and that's why it's important not to use occlusive dressings like a hydrocolloid, because these dressings can cause maceration of the surrounding skin. It is recommended that the skin is protected with suitable barrier products in liquid, paste, or solid forms. And there, if we will try to fix the fixation of these dressings, we can use regular sport bras, we can use tubular gauzes, bandages with a silicone layer, or gauze bandages, or dressings retention garments. If we talk about bleeding or hemorrhage of these wounds, there we have a substantial risk of trauma. We have this may be caused either through us nurses when we remove the dressing. That means I would recommend there to wetten the dressing, not that it is sticking to the underlying surface of the wound. That means you can use either warm, normal saline irrigation to moisten the dressing, or if the patient is, if it's possible for the patient to take a shower, you can use the regular water to loosen the dressing and to root to dressings. Otherwise, we recommend to use non-adhering dressings and moist wound products if it's possible. If bleeding occurs, it can be that it is heavy bleeding, or it can only bleed a little bit in the wound. If there is heavy bleeding, we recommend to take a towel, like from the OR operation room. That means it is either green or green or blue. You can take that towel and press it against the wound so that it has a little compression. Otherwise, if you explain bleeding to patients and informal carers, especially if these patients or informal carers are doing the dressing change, then we can recommend tranexamic acid. So like fizz tablets, or you can use calcium alginates, but it's important if you use calcium alginates and it's bleeding, then it can get very thick and alginate doesn't act correctly. Otherwise, if it's heavy bleeding, you can use either a radiotherapy or electrochemotherapy that can help to control repetitive bleeding. Let's talk about physical pain. Physical pain is very significant, and it's a very complex phenomenon in malignant fungating wounds. We have several factors that can cause this pain in these wounds. First of all, we have the pressure of the tumor on other body structures like bones, for example, or we have the damage to the nerves caused by the growing tumor. We can observe also swelling resulting from impaired capillary and lymphatic drainage, infections because in these wounds we have a lot of bacteria, we have colonized wounds. Then we have the exposure of dermal nerve endings, and we have the exchange of wound dressings that can be caused through us, nurses, or through patients and informal carers. What do we suggest if patients have suffer from pain? Of course, a pain assessment. Then we recommend to give, prior to the dressing change, some analgesics or a booster dose for the usual, their usual opioids, some anesthetic drugs recommended by the WHO. But there I have to add something, that about 70% of wounds, of regular wounds, they have the origin of the peripheric and the central nerve endings. That means that we have, for the central, we can use the analgesic drugs from the WHO's, and the others we use like other drugs like antidepressants, for example. Then, of course, when we cleanse the wounds, we have to look if there is the saline is warm, not that the patient suffers if we use a cold saline. Then I would suggest that you rather rinse the wound and don't use syringe. You can use gentle gauze swabs to dress this, to cleanse these wounds. Regarding dressings, we recommend non-adherent wound dressings that are moisturized with saline, for example, or you can even use the topical application of opioids. We just recently published a literature review where we found that about 10 milligram morphine in 8 gram hydrogel is suitable for these wounds, and that's the recommendation. Please don't mix this morphine and hydrogel. It has to be a pharmacist that has to mix this, and the morphine has be prescribed by a physician. Do you have any questions?
Thank you. We had one question in relation to electrochemotherapy and wondered about your experiences of using that
Yes.
in whichever of the symptoms that you wish to manage.
Mm-hmm.
Do you have any experience of using that?
Which product? I didn't get the last couple of words of the sentence.
I beg your pardon. For electrochemotherapy?
Electrochemotherapy. It's in some countries it's used. In other countries it's not used, and we can recommend that for bleeding. We can recommend that I can recommend that for treating, managing the wound, especially if the wound is growing very fast or the tumor below is growing very fast.
Okay. Thank you for now. Thank you.
You're welcome. Let's talk about the psychological impact. Before we were talking the symptom management, I already started a little bit with the psychological aspect of these wounds. We were talking about odor. Patients are mostly very embarrassed having these wounds. They are not showing these wounds to their relatives, and one aspect is because of the malfunction of the body. You have to imagine you have all of a sudden a lot of exudate, then you have no exudate. It can be that you're, for example, if you have breast cancer and exaggerated breast cancer, that your blouse will get wet, or even if there is some bleeding involved, that your blouse will get blood there. Then mostly these wounds are incompatible with our culture. That means being sick, having this wound is not healthy. It is a stigma. It has mostly a negative effect on the psychological well-being of the individuals. That means that patients have firstly to accept the situation in which they're living. They have to talk to relatives. Some patients, they do not show that to their relatives, do not show that even to their husbands, to the children, so they keep that for themselves because of the embarrassment. Let's talk again about this malodor. It's, as I already mentioned, it's one of the worst physical symptoms for patients. You do not know when you walk around, when you do your grocery shopping, for example, or go and visit a friend, or friends are visiting you, if you smell like rotting flesh, most of the friends, relatives, they think it's either it's a bad hygiene, and this rotting meat, this odor, increases the sense of the embarrassment, the shame of the patient. Most of the patients will be socially isolated, and they can develop even a depression. Regarding pain, it's mostly the psychological pain. It's not seen or cannot be managed with analgesia. Mostly it's associated with the fear that if I change the dressing, if I move, or if I do a movement, that it hurts. It's the anxiety. And most of the patients, they stay at home in their chair, for example, and this is again a factor that can develop a depression and the social isolation of the patient. Exudate, as I already mentioned, it's the uncertainty and unpredictability if this wound or the wound dressing is leaking. One patient told me, oh, I was at your medical office, and when I was at home, my wound was leaking. I didn't know what to do. So she was taking household paper and was stuffing that in the wound because she felt so embarrassed that it was leaking. It's mostly living in a body that cannot be trusted. That means I don't know how much exudate do I have, or does the wound develop? How many body fluids should be contained within this within the body? That means what kind of dressing do I have to take? And this is another factor that patients will get isolated, and mostly from the society. Bleeding can bring uncertainty and psychosocial distress to the patients. They don't know when it bleeds, how does it bleed. It's the frequency of dressing change. can change and affect the lived experience of these patients. One example, one relative told me, I found my mother in her bed, in her white sheets, and she was literally bathing in her blood. And you can imagine seeing patients or seeing your loved one in a bed full of blood. That is a big fear for the relatives, that they think, oh, my mother can die shortly. Let's go to the take-home messages, and then we have some further questions. So managing fungating wounds, it's very challenging for patients, families, and even for us healthcare professionals. We have to take a palliative approach to provide a good quality of life for our patients and their relatives. The care should be planned individually, as the feelings of these patients are very individual, and we have to talk to them, we have to involve their patient, their relatives in the care of fungating wounds. The wound-related symptoms like malodor, bleeding, exudate, pain, and itching should be managed in a very effective way. We can propose patients different kind of methods how to manage these wounds, and of course we have to think about the psychological impact of these wounds, and it has to be underestimated. So we have to support patients and their informal carers. Here we have some references I was using during my talk, and I would like to ask Dr. Getting if there are any further questions.
Thank you very much, Dr. Probst. Can you hear me?
Yes, I can hear you.
We have a few questions, and also quite a few people complimenting you on an excellent presentation. So I want to say that first.
Thank you.
One of the questions is, can you crush metronidazole tablets or flagyl tablets to apply to a wound?
Yes, you can crush these tablets, and so you have a powder, and you can apply this powder directly on the wound. And I have to say, we are in a palliative situation. We are not in a curative situation. That's why we can use antibiotics in wound care. Otherwise, we do not use antibiotics in wound care. Palliative situations with fungating wounds, yes, we can crush them, we can apply them directly on a wound.
Okay, thank you. Another question, do you have any comment about topical 5FU, or do you have any experience of using that?
What's topical FU?
5-fluorouracil?
Okay. I've used it once and it worked very well, but in certain countries it's difficult to access. I've realized that, but it's one of the possibility to use it. Yes.
I have two more questions. One is, and this is through your own research and your presentation, the profound issue of isolation that people feel.
Yeah.
And, you know, how can we involve relatives more in helping people to cope and to manage in order to reduce isolation?
If you manage wounds at home, for example, it's important to show relatives how to manage the wound, where to access of interest. You have to do that together with them, not doing that with only with the patient and their relative is not involved. Like that, you can talk to the patient, you can talk to the relatives, and one of my results of my research is give them a little, like a recipe book. How can you manage this? If it bleeds, you can take this. If there is a lot of exudate, you can use this product. Where you can access these products and give a number. If they have any questions, they can call you or call your service. Like that, you can talk to the patients and you can help them to cope with these wounds.
Thank you. I think that's very useful. The final question I have, and one or two people sent this in, is how can we get the guidelines, or when will they become available?
I was talking to the educational group of EONs, and they told me that the guideline should be available in the next couple of days, as they had some problem with printing it, and then they will upload the guideline on the EON's homepage.
Thank you very much. We look forward to that. That ends our discussion. Thank you, Dr. Probst, for an excellent presentation.
Thank you, Dr. Getting, for the questions, and thank you very much for the participation of this session.
Thank you.
Thank you.